Good evening, students. This is Dr. Fitzgerald, and I'm recording our lecture material for Chapter 9, Communication Strategies Training, and Chapter 10, Counseling, in our Ty Murray text, Foundations of Oral Rehabilitation for Children, Adults, and Their Families. I'm recording this lecture on Thursday evening, June the 29th. It is the content material for the week of July the 5th. This material will be on our online midterm exam. That exam is open July the 5th through July the 10th. There are chapter questions due for Chapter 9 and Chapter 10 that are due Wednesday, July the 5th. Make certain that you complete your chapter questions and that you listen to this archived lecture before you attempt to take your midterm online exam. We are going to be talking about communication strategies training, which is in effect the R in our core and care modules. So in our treatment module, C-A-R-E by Shao and Nirvan, the R stands for remediate communication status. That does include auditory training, speech reading, speech, language, and literacy training if we're dealing with children with hearing loss. But it also includes a very significant portion of teaching our clients how to take control over their communication difficulties. So one goal of communication strategies training is to help our patients increase their sense of self-efficacy. Self-efficacy, from page 319 in your textbook, is that confidence a person has for being able to perform a specific task. So one of our goals in teaching our patients communication strategies is to increase our patient, whether they are children or adults, to increase that sense of, I am capable of dealing with this situation. I am capable of effectively communicating in my everyday activities. Remember, that is actually one of the World Health Organization's goals that all of us as healthcare providers need to be thinking about. Our goal is to increase our patients' ability to deal with the situations that are challenging for them. And so communication strategies is one of the ways we help them bolster their self-efficacy beliefs, believing that they can be successful, they can live well with hearing loss. So tonight we're going to talk about how we as SLPs do that. Again, it's extremely important that we help our children and our adults believe that they are capable individuals. It's not unusual to hear people with hearing loss have self-perceptions where they feel that they're a burden to others. They want their hearing loss corrected or fixed with hearing aids, cochlear implants, BAHAs, FM systems. And it's often frustrating to the patient themselves, their spouse, their family members, when they aren't able, again, to have perfectly normal hearing again. So one of our therapeutic goals is to incorporate into our therapy helping our clients develop a more realistic appraisal of themselves and their hearing problems. And we do that by instituting specific therapy goals related to communication strategies. Again, self-efficacy, which is the ultimate outcome, we hope, of our remediation, refers to the belief that patients have about their ability to manage in difficult communication situations. That belief influences our patients' willingness to engage in social activities and conversations. That's particularly critical for adults, where we're trying to avoid the withdrawal, the social isolation, the depression that often accompanies hearing loss. It's also critical for our children and adolescents who frequently have some difficulty socially interacting with their peers because they don't believe that they are successful, or they don't have the social pragmatic language skills to be able to negotiate the preteen, the adolescent world, the young adult world. So one of the ways your textbook on page 319 talks about ways to encourage this self-efficacy is to give patients experiences that show them, I can do this, I can be successful. Here is how I can have a successful conversation, a successful interaction. And one is simply to observe other people with a similar kind of problem, a hearing loss, be successful. Simply watching. That's why a group experience, whether it's an adolescent group experience in a school setting or a group experience in a skilled nursing facility or long-term care experience, often simply seeing others similarly situated be successful is encouraging. It's also true that we as the clinician can act as a comforter, a support, explaining to our students, our patients, ways to manage difficult situations, tools, and we are going to talk and did talk some last week about tools to give the patient. It's also important that we recognize and that we are sensitive to when a patient is really very anxious, so fearful of engaging in social conversations or going into groups or going to outings like going to the theater or going to a lecture, that we recognize that for some of our patients that very thought is anxiety producing, and that we may in fact have to help them work through that anxiety. When we talk about developing a therapy program, we can talk about communication strategies being provided in a variety of different ways. We certainly can provide that one-on-one. And sometimes we work with patients who are so hesitant, who are so resistant, who are so unmotivated, that we really need to see them one-on-one to begin the first steps. Oftentimes we provide that training for adults in a couple session where we involve the most frequent communication partner, the spouse, in a process. We very frequently do provide this kind of communication strategies training in a group setting, which the research would tell us may be the most effective way to do that. If we look at some of the research, particularly the research by Jill Preminger, which I put up in eLearn as one of the attachments, both in the content section and attached to the news section in eLearn. She has done some research simply looking at how people who have hearing loss, adults who have hearing loss, see their views about their hearing loss. And this slide talks a little bit about how important is it to you as a patient to be with people who have similar hearing problems, to learn how other people cope with their hearing loss, to understand the feelings that others have about their hearing. And as you can see on the right-hand side of each of these slides, that appears to be somewhat important or very important to our patients who receive hearing aids or cochlear implants or BAHAs. So when we get started designing a program, thinking about a curriculum, one of the first rules, the most important rules, is to recognize that whatever program we develop has to be catered to the patient's concerns. That's why we've spent so much time last week talking about assessing what the patient's situation is, having the patient use something like the COSI, the Client-Oriented Scale of Improvement, to tell us what are the most difficult and challenging situations. It's also important whenever we begin thinking about a group presentation, for example, in a long-term care setting, or a group meeting of preteens or teens in a school-based setting, that we set some ground rules, that we look at how the group gets structured so that we have a group that is effective for everyone, that we don't have one individual monopolizing the group, and that we deal with in our discussions, our illustrations, our role plays, our simulations, that we're dealing with communication difficulties that are common to the group. One of the things that Nancy Time Murray introduces in your textbook on page 322 is sort of this stages of communication strategies training. Now, many of you who are teachers or who have done other clinical work as SOPs will recognize that this stages of communication strategies training, beginning with formal instruction, leading to guided learning or guided practice, and then moving that new skill into real-world practice, is a model that's often used anytime we're trying to change a behavior or learn a new skill. So this model for training, this framework for conceptualizing the stages of communication strategies, training, or therapy shouldn't be unfamiliar to you. Again, formal instruction is where the group leader, the SOP, presents various types of communication strategies, talks about appropriate listening and speaking behaviors, provides examples or illustrations, and the clinician then can ask members of the group to talk about how they have managed their own communication difficult situations. The leader of the group, the SOP, can help analyze and evaluate the various solutions that come from individuals within the group, write patients' ideas and responses on a whiteboard. During guided learning, we then move into a more active phase for all of the individuals in the group. So this is the stage where we encourage the group participants to actually use conversational strategies that we're talking about. And we encourage them to use those strategies that we've been talking about by modeling them, by role-playing, by analyzing a videotape scenario, so that we are giving our group participants, who are our clients, we're giving them practice under our watchful eye in a group where there's support, where we can help them correct any problems that come up. So we are looking, again, whether it's children or adolescents, whether it's adults, we are trying to set up simulations or experiences and then talk about what happened, what worked, what didn't work, which communication strategies were implemented. And we can use prompting and shaping and reinforcement and modeling and feedback, just as we do in any other situation, to make sure that our patients have the skills well in hand. And then we're going to have them move those skills into practicing in the real world. This last strategy, continuous discourse tracking, is discussed in your textbook on page 327. Remember, continuous discourse tracking is really an example of guided learning. This is the thing that we talked about last week. Continuous discourse tracking or training is an AR technique in which the listener, our client, attempts to repeat verbatim text presented by a sender, usually the therapist. So the sender is the participant who presents the message. The receiver is the participant who actually receives the message and attempts to repeat it back verbatim. And there's an example, again, in the text box on page 327, where the therapist is reading a story, a passage, and the receiver, the person with the hearing loss, is telling what they got, how much did they understand. Sometimes, if it's hard for our patients, we provide a picture to support the text, or we provide key words before we begin the passage. But when the individual has trouble, can't repeat the text verbatim, we might say something like, let's try that again. We might encourage the receiver, the client, to say something like, can you tell me that in a different way? That's one of those repair strategies. So we're looking to see, one, is our patient using any of the repair strategies that we've been encouraging them to adopt? Can they recognize when there's a breakdown? And again, we can model that for them. The advantage of being in a group situation is that participants within the group can pair up and practice this continuous discourse tracking as an activity for 2 minutes or 3 minutes or 5 minutes. But it's an example of guided activity. We certainly can model, and oftentimes we know that with our clients who are either new to this idea of communication strategies training, or who are very hesitant, diffident, uncertain, that it's often modeling so that we allow our more hesitant, more unsure participants to observe. So again, the clinician might model, another student might model the use of one of these specific repair strategies. And we're hoping that what happens is the others in the group are picking up on, one, how do I do this? How do I use that? And what happens when someone does use a repair strategy, the communication moves forward, and the individual gets to see, oh, using these repair strategies works. It worked for him, it worked for her. Maybe I should try that myself. We oftentimes do use role-playing, again, where either with the clinician and one member of the group or with two members of the group, we actually practice. Again, where the therapist can prompt, can shape, can reinforce, can model, can give some feedback on the interaction. We also want to make sure that we focus everyone's attention on identifying and rectifying the problem. So if it's an environmental problem, if it's a loud, noisy restaurant, if there's lots of noise, background noise in a home setting, we want to focus everyone's attention on what is the problem. The problem is in the environment, the E. How can we rectify that? Or the problem may be that the talker, the sender of the message, is not using clear speech, is not providing a good model. Sometimes we use videotapes. Oftentimes, if we are beginning in a group, particularly I've found with preteens and teens, when we begin these social, pragmatic communication strategies, group experiences, sometimes simply a videotape of others experiencing problems and others solving their problems by using communication strategies is a gentle way to get the group to be more interactive, to participate. It's a lot easier to criticize or to model after a videotape, maybe not quite as personal as a role play or actually doing it yourself. So again, you as the SOP, the clinician, are going to guide, give tips, suggestions on how to make this communication conversation work better. Once you're confident that the people in the group, or the majority of those in the group, or certainly your client in a one-on-one situation, or your client in a couple's situation where you actually have a spouse with you, or a parent-child therapy situation where you're convinced that everyone is able to carry out the newly learned communication strategies. Then you assign that to real-world practice. So you have students perform those repair strategies in a real classroom setting. You can give the students simple, concise written directions. You can have the students maintain a record of their experiences, and then at the next group therapy, you share So here's simply an example of when a particular patient actually did real-world practice. This is a calendar for recording that real-world practice activity. Is on page 329 in your textbook. So you're simply asking your client to actually record, did I practice? Where did I practice? With whom did I practice? Oftentimes, though, it's important for us to recognize, as we talked a little bit last week, we are not going to be seeing patients with hearing loss for long-term therapy. We may do a short period of group therapy, for example, in a skilled nursing facility or a long-term care. We might do a short period of communication strategies training with new adult cochlear implant users. We might do a brief period of group therapy with children with hearing loss in a school setting. But there are also many cases where it's simply not feasible, particularly with working adults, particularly in long-term care settings where we have many patients to see with disorders such as swallowing disorders that are clearly reimbursable. Our ability to provide other kinds of extra services, including auditory training, which does have its own CPT code. You as an SOP can charge for it, but if it's not on an order, you may not be able to provide that. So you don't have the staff, the patient doesn't have the time, then what can you do? What is your responsibility to persons with hearing loss? To provide some help absent longer-term therapy, even really short-term therapy. And there are a couple of ways to look at it. We've talked about some of these a little bit last time. It is certainly true that as an SOP you should have in your toolkit, your toolbox, some materials, printed materials, recorded materials, so that you can create sort of a little library of materials to share. I'm hoping that when you do your course resources project, you are going to look for some of these one-page simple handouts, simple pamphlets that are available for you to share with patients and their families, teachers, parents, so that there is some material to share. One of the types of short-term tutorials on page 331 in your textbook is called Watch. It was originally created by Alan Montgomery. And it simply is another one of these mnemonic devices that will help your patient understand how to improve their communication strategies with what is essentially a short tutorial in about an hour. Again, might be 4 15-minute sessions. You can discuss with the patient each of the concepts in order in Watch. A short program like Watch doesn't do everything that a patient might need, but it's simple, it can be reviewed, it can help a patient at least move in the direction of, I'm going to try to solve my communication difficulties by taking some positive steps. Sometimes we can have patients who have been presented with something like watch, and then at a later time have them agree to enroll in a more extended communication strategies training program. But watch simply means watch the talker's mouth, not his eyes. That's simply an admonition to speech read. Ask specific questions. When you don't understand, acknowledge a communication breakdown and ask specifically for what you need, or tell your message sender, here's what I understood, but then I didn't understand the rest of it. T, talk about your hearing loss. Let others know that you have a hearing loss. That oftentimes is simply the key to having speakers or partners make more of an attempt to help the patient with a hearing loss understand. Change the situation. Cut down on the noise. Move closer. Ask for picture cues. And then H is acquire healthcare knowledge. What we want our patients to understand is that they can look at getting more information. What are their rights under the ADA and under Section 504? What are some of the strategies or other technologies that might be available to them in addition to their CI, their hearing aid, their BAHA? The other short-term tutorial that we did talk about last week is the communication strategies training for frequent communication partners using the little acronym SPEECH. This is the one-page handout, the short tutorial that we provide for the partners of our persons with hearing loss, parents, teachers, co-workers, peers and spouses, healthcare workers in a setting where they are dealing with a large population of individuals with hearing loss. So simply teaching others, again, in this idea of a short-term tutorial. Again, we talked several times in this class about the fact that the research clearly says that looking at the partners and trying to change the partner's behavior is oftentimes half the battle. So a parent, a teacher, a spouse, another healthcare provider, a CNA, who is using good, clear speech, using the SPEECH acronym, is a tremendous help to our patients with hearing loss. So again, as we've said before, oftentimes the target of our therapy is not the person with the hearing loss, or that person is not the only target of our therapy. Another target of our therapy is these frequent communication partners. So we want to teach them to spotlight your face and keep it visible. Absolutely. Think about the teacher who talks mostly to the whiteboard or looking out the window. Pause slightly between the content portions of sentences. We talked last week about how that brief pause at the end of an intonational phrase is exactly where the central auditory nervous system actually does the processing work. And when we're looking at our persons with hearing loss who also have, in addition perhaps to a peripheral hearing loss, they have a central auditory processing issue or simply slowed processing time overall. It's those little pauses that allow the central nervous system to process that information. So encouraging frequent communication partners not to slow down the overall rate of speech. That distorts, that makes it harder, but to stop at the commas or to stop at the end of an intonational phrase. Emphasize and be patient with the person with the hearing impairment. Emphasize key words so that even if the patient doesn't get the entire message, they get the key words and then can use their top-down, higher-level language skills to infer what the missing portions are. Ease their listening. Get their attention before you speak. Make sure that you are helping them by letting them know I'm getting ready to say something that's important. Oftentimes just calling their name will alert a patient that they should turn and look at you and listen. Control the circumstances and the listening conditions. Again, we keep coming back to this. It's the E in our care model. Maximize communication by getting closer to the person with a hearing loss. Moving away from background noise. Maintaining good lighting. And then have a plan. The H in speech is have a plan. Anticipate difficult listening situations. Think of some strategies in advance. Asking the wait staff at a restaurant to seat you in a quieter corner if you already recognize that that's going to be a noisy place. Choosing a quieter restaurant if you are going somewhere with a family member who does have a hearing loss and struggles in noisy situations. So these two short-term tutorials, again, certainly not more than an hour, might be done in a single counseling session, might be broken down into 2 or 4 30 or 15-minute sessions. Nancy Ty Murray actually has looked at some research where she looked at what happens in instances where children with hearing loss misunderstood the directions, and she gives you a little scenario about the mint activity, unwrapping the mint, and what students misunderstood and how that, what kinds of strategies they use. She did it where the mother of these children was the sender of the message. So this is a parent-child dyad, a parent of a child with hearing loss, and looking at repair strategies that were used. So repair strategy 1, the mother simply repeated, and the child didn't understand. And so the mother quit. She repeated a couple of times and then she quit. In repair strategy 2, the mother rephrased. Still wasn't understood by the child, but the mom emphasized the key word. Where's the candy? And the child picks up the mint, and the mother says, open it. And the child begins to unwrap the mint. So again, repeating doesn't always work. In fact, it's not an effective strategy in many cases. Rephrasing is an effective strategy, and providing a key word is an effective strategy. And reducing the length of the message is another strategy. So simply looking at this research, which has been repeated not only with mothers and children, but with spouses and other types of partners, the repeat repair strategy isn't always the best. And if we can help frequent communication partners understand that, try something else, try rephrasing, try providing a key word, try breaking down the message. So it's often true that the key communication partners simply don't understand these strategies. And one of our roles in easing the conversational fluency and the communication success is to train these partners. Frequent communication partners, by participating in therapy, are also getting some indirect support and counseling. Frequent communication partners of people with hearing loss often tell you that they do suffer from stress. They do find themselves often irritated or tense, or just resigned to not having meaningful, intimate, in-depth conversations. That's one of the reasons that your discussion forum assignment for this upcoming week, again, not due until next week, but is to have you use the CID everyday sentences from the back of Chapter 2 in your textbook. Those CID everyday sentences begin on page 79. And I want you and a partner, your spouse, your child, a neighbor, a coworker, anybody you can coerce into helping you, to practice those different lists using the scenarios that I outlined in the discussion activity. And I want you to be both the sender of the message, so in effect a partner, and I want you to be the receiver of the message for some of the other short scenarios, so that you get a chance to both experience what it's like to have a hearing loss, but also what it's like to be the frequent communication partner of a person with a hearing loss. And then I want you just to comment on what you learned about, I'm hoping it will help you develop empathy, not only for the patient, but also for their partners. Again, if we look at some of the research done by Jill Preminger, you will see that she has spent a lot of her research career looking at what is the long-term effect of audiologic rehabilitation communication strategies classes. And again, the majority of the frequent communication partners, now this is not people with hearing loss, they did better too, but an interesting corollary of these groups that involve frequent communication partners. The majority of the partners reported that they did learn something in these little classes. They learned how to increase their own use of communication strategies, and that actually led to a reduction in their assessment, their perception, their self-report of the hearing handicap across all of the subject groups with hearing loss and the significant others. So the greatest reduction in hearing handicap based on self-report was measured by the subjects who attended the class with their significant others and essentially learned together. So what kind of goals do we have? Is it appropriate for us to target somebody who doesn't have a disorder, who's just a partner? And the answer is yes. We have models of that in lots of other communication disorders. The Hannon program that trains parents of children with delayed or disordered speech. The focus of the therapy is in fact parents, teaching parents how to more effectively communicate with their children who are struggling to learn language. So it's not unknown or unusual for SLPs to target someone other than the person with the disorder. So the goals for training frequent communication partners include, again, helping to foster empathy on the part of the partner, encouraging the use of appropriate speaking behaviors, helping that partner learn how to tailor messages to be easily recognized, to use keywords, to reduce the length of the overall stimulus, learning how to repair communication breakdowns effectively. Again, it's a two-way street. So teaching those partners to use keywords, to spotlight their faith, to use rephrase rather than just repeat. Again, helping the partner develop empathy, recognizing how hard it is to actually do a speech recognition task when the audio signal is not clear or not good. How hard it actually is to speech read. So again, helping frequent communication partners appreciate that their significant other may be experiencing fatigue, a desire for social withdrawal. One of the things that there has been lots and lots of recent work on is this idea of fatigue. I think I've talked about it before. I know when I went to Italy last year to present a paper on auditory processing at a big international conference called the HEAR conference, I was struck by how much of the research focused on this idea of fatigue that people with hearing loss experience, from college students to older adults to children, measured in all sorts of ways by different researchers from different countries. But the idea was that those of us with normal hearing don't really appreciate at the psychological level how challenging it is for a person with a hearing loss to try to listen. And that's why we see children literally come home from school and they are exhausted. That's why we see some preteens and teenagers who will tell us, I have to have the weekend to recover. And why you hear college students say, I have to schedule my classes so I have some downtime, again, to recover. I'm so fatigued by listening to a lecture. So I think that, again, one of the goals of frequent communication partners being included in communication strategy training is simply to help them gain some empathy for exactly how hard their significant other is working, as well as to develop appropriate speaking behaviors. It's clear that we are teaching them techniques, strategies, so that they are using these strategies so that they are good speakers for their family member or their patient. Teaching our CNAs to use these techniques is an important service to our patients in skilled nursing facilities and long-term care. Helping our frequent partners to realize what are the things that make it hard. It's hard if you have too many words. It's hard if you use ambiguous sentences. So simply paying some attention to the characteristics of the message that they're trying to present. Can I think of a way to rephrase that organizes the message in a better way? Can I encourage partners to ask the person with a hearing loss if they comprehend it, to ask for verification, to provide feedback? And it is not, did you understand? Because if you ask that kind of yes-no question, did you understand, there is always a bias, whether it's a young child, whether it's a working adult, or whether it's an older person. There's always the bias to say yes when I didn't understand at all. I'm bluffing. It's easier to say yes. And so you need to ask for verification. Tell me, when are we going? If you just said, we're going to go at 10:30 to blah, blah, blah. Ask for verification. Ask a real comprehension question. Ask for feedback. Don't ask, did you understand me? Because then you get that yes when I didn't. So we do want to teach these partners to what to do when the communication breaks down. It is true that the partner of a person with a hearing loss does bear at least 50%, maybe 75% of the responsibility for repairing breakdowns. So we want to coach these communication partners about how they use repair strategies. We want to give them this practice. Just as we're practicing with clients, we want to practice with their partners. We want to make sure that the frequent communication partner is using what we call clear speech. And clear speech is speech that is presented at a normal but moderate rate, that it uses precise articulation, making sure that the consonant contacts are clear, that it pauses between intonational phrases, and that it emphasizes key words. So we want to make sure that the partner knows how to use clear speech. You as an SOP use clear speech almost all the time when you're working with patients or students. But if you look at the population in general, not everyone uses clear speech. But it is certainly something that anyone can learn to do. And so we literally train clear speech in the communication partners, and we practice it. If we look at some of the research that's been done with children with hearing loss, we see that children, in terms of the strategies that they use, they most often use repetition. Then next most often or most frequent is revision and additions or expansions. The least used strategies by children are simplification, cueing, offering background information, or some inappropriate response, an unrelated utterance, simply turning away or discontinuing. So when we think about those strategies, this has been done in groups of children with normal hearing, groups of children who are hearing impaired but have good speech intelligibility, and groups of children who are hearing impaired with poor speech intelligibility. What happens is that among those different groups, you do see some variation in how they use communication strategies. And so what we want to do is look at this opportunity that we might have to work with children who, again, upper grades, preteens, teenagers, and talk about what kinds of communication strategies might we use. If you look in your textbook on page 336, 337, 338, and 339, you see some plans for how would I do this in a school setting. And again, it follows the basic model: formal instruction, guided learning, and real-world practice. Formal instruction for children includes just a review of effective listening behaviors, talking about talking, paying attention, watching the talker's face, trying to identify key points, asking talkers to clarify their messages. And then, once the participants in the group understand what communication strategies are, you do some guided learning. Again, you might actually go and do a simulation, do a role play, look at a book that tells a story about a character using specific repair strategies. And then you actually help the students transfer their use of communication strategies into natural settings. So you practice with different talkers in a variety of situations. Within a school setting, you go to the office, you go to the cafeteria, you go to the library. So you're giving your students an opportunity to do real-world practice. You may particularly want to look in your textbook on page 339 and look at a program adapted from Jill Elfenbein that looked at how do you teach children, students, communication strategies, particularly dealing with these communication breakdowns. So she's got a 5-step lesson plan for how one moves through that kind of group. Again, you're always trying to push your students to move into real-world practice activities and to actually learn to monitor their communication strategy use in some real-world setting. You want to encourage them to use expressive repair strategies. Again, what do you do when a child presents a message using speech and it simply isn't clear? How can the child take some ownership to repair the communication breakdown? Does the child have enough tolerance of that negative feedback? I didn't understand you. Can you say that again? To try again, to tune up their speech, to add some hand gestures. one of the things that we have to do is help our hearing impaired kids take ownership of their hearing loss. Sometimes they're not going to be clear. Sometimes others are not going to understand them. And we have to help them be resilient enough to be assertive, to say, okay, let me try to tell you that again. Let me tell you in a different way. One of the things that we do want to build in our young children with hearing loss is not only self-advocacy skills, but this good use of expressive repair strategies. Not to immediately go, okay, they didn't understand me, so I'll just not try anymore. Or to look immediately to a teacher or a parent or a sibling to interpret. Again, we're trying to build their independence. We're trying to build their self-efficacy so that they think, believe that they can solve their own communication breakdown problem, even if it's just for this one brief encounter with a partner who doesn't understand them. So again, we want to make sure that we use maybe this 5-step training plan by Jill Effenbein on page 339. When we have students with hearing loss who seem to be making good progress or attempting to use their oral speech, but are not so clear and so perfect that they are always intelligible to others. That would be the vast majority of our children with hearing loss. Need some work on how can they be more effective in communication, conversations with others. And so we use that 5-step model. Unfortunately, if we look overall at what is the research talking about the benefits of this kind of training, what do we know from solid evidence-based practice? Most studies have reported some reduction in the perceived hearing-related disability. So patients self-report and partners self-report that counseling and communication strategies-based AR programs do help. But it's also true that some of the research has reported no significant reduction in the self-report of disability. And some have had mixed results. So both for adults and for children, the last couple of pages in your text does do just sort of a little summary of the benefits. I think we have to be honest as critical users of the research that's out there to say it is promising, but it is not conclusive. And so that is often the case in many areas of therapy. We have promising techniques that are worthy of more exploration, but we, across our field of communication and sciences and disorders, there are lots of things that we do that don't have absolute, unequivocal, robust research findings. And it's important that we are honest about that we say more study is needed, but these are promising techniques. So typically the benefits occur most frequently when there's good patient participation. We do see a change in communication strategies usage, and we do see a change in this self-reported or perceived hearing-related disability. Following AR programs, the majority report a more relaxed relationship with their hearing impairment, a sense of having learned how to live with it. Sometimes individuals will express this increased sense of self-efficacy. It's not perfect, but I think I can solve most of my communication challenges. And that's what we want for our patients. We want that sense of, I can live well with a hearing loss. The hearing loss didn't go away. I still have it. I still face challenges. But I have some strategies to help me be more effective in the daily activities that I want to engage in. So if you look, again, at various studies, you do see that with training, people do make progress. Children make progress, adults make progress. So they can learn these strategies. That empowers them. They feel like they can manage their environments more effectively. But it's certainly true that it is not 100% effective, and it's not effective for every patient. I'm going to take just a quick break. You can pause this archived lecture if you need to take a little bit longer break. I'm going to take just a moment's break while I switch to the next set of slides as we move on to talk about Chapter 10, the counseling, psychosocial support, and assertiveness training that frequently goes hand in hand with communication strategies training. Okay, let's resume again. Let's talk about counseling for individuals and families dealing with hearing impairment. We are in Chapter 10 of the Nancy Ty Murray text, Oral Rehabilitation for Children, Adults, and Their Family Members. Chapter 10 begins on page 350. So we're going to talk about why would we specifically in talking about oral rehabilitation talk about counseling. And the answer is that's where it starts. The answer is you have to begin at the beginning. And research across families dealing with young children diagnosed with hearing loss, individuals who suddenly have an acquired hearing loss, adults and seniors who experience a decline in their hearing. Counseling becomes a critical element. And if we think about our CARE model, C-A-R-E, the first C is counseling. Audiologists have recognized for years and years that counseling is a critical element in therapy, particularly for this population, because hearing loss of the kind, permanent kind that we are dealing with in patients with significant hearing loss is not something we can fix with a pill or fix with a device, or at least, given our current state of medical knowledge, fix with a surgical intervention. We are making very rapid progress on the medical front. We may well be able to actually restore hearing for many individuals, certainly within your professional practice careers. But right now, we are faced with a large number of individuals for whom we can ameliorate the problem. We can maximize their ability to cope with the problem using excellent technology, but we can't regenerate hair cells. We can't regenerate nerve cells. And so at some level, we are faced with a permanent condition, a permanent disability with a bodily structure or function. And we also have to recognize that hearing impairment, because it's so integral to our functioning as human beings and being able to communicate, hearing impairment has an impact on people's emotional lives, on their daily living. So we're going to talk a little bit about how do adults react to a hearing loss, how do significant others of those adults react to the hearing impairment, how do parents react to a hearing loss in their child, what is the impact, again, of this stress related to hearing impairment, and talk about the counseling techniques for families of children and counseling techniques for adults with hearing impairment. All of us have had, and you certainly have had, Dr. Johnson Arnold's excellent course in counseling. And we've all talked about the stages of grief, the traditional stages of grief, originally elucidated by Kubler-Ross back in 1969. And many have said that dealing with a severe hearing loss is like dealing with any other loss, so that we see denial. And particularly with hearing loss, we may very early see denial. It's the invisible handicap. You don't see it immediately when you look at a person with a hearing loss. Oftentimes individuals go through that stage of anger. It's unfair. Why my child? Why me? That next stage of bargaining, just one more day. Could we just have one day without having to deal with these hearing aids? Could we just have one day where I didn't struggle in communicating with others? Then we oftentimes see, and more and more we are getting research confirmation of depression and the link between hearing loss, social isolation, loneliness, and depression. Particularly the work of Dr. Frank Lynn, which I've talked about, the Baltimore longitudinal study on aging, looking at what happens particularly to our seniors. We're going to talk more about that in the next couple of weeks in this class as we delve specifically into looking at adults who have hearing loss. But I think it's also important for us to recognize that not every person moves through these, quote, stages of grief in a linear manner. Not all family members experience that sense of loss. Certainly, if we look at members of the deaf culture, deafness is simply a characteristic of many people in my family. Deafness is not a bad thing. Deafness is simply who I am. So before we automatically say every family goes through stages of grief, every person with a hearing loss goes through these classic stages of grief, we need to stop short and say that's not always true. Kubler-Ross's stages of grief do in some respects, give us a window on what may be going on with some of our clients. But they're not universal, and not everyone goes through those stages, And our goal is not simply to help them move through those stages quickly so they will get on with working with their child if it's a family member, or get on with using their hearing aid or their cochlear implant. Oftentimes we see that individuals cycle through these stages so that we may at some point in time reach an acceptance where the person acknowledges the hearing loss, is ready to develop coping strategy, and then an event will occur, a situation will occur, and they cycle back into those earlier stages of anger and bargaining and depression. There has been a lot of research talking about the social and emotional issues related to hearing loss, particularly when one acquires a profound hearing loss, such as an accident or an illness where a person had normal hearing or near normal hearing and suddenly acquired a severe to profound hearing loss. The research would suggest that that probably is the most devastating social and emotional effect. But even gradually acquired mild and moderate hearing losses, like the gradual onset of presbycusic loss, does have an effect on behavior, on thoughts, on emotions, and relationships. So there are these psychosocial consequences or effects. Oftentimes we see effects on individuals' behavior. They try to escape, withdraw. They pretend to understand. We talked about that bluffing. Or they dominate the conversation. They have a very aggressive, domineering, dominating conversational style. Because if I'm up doing all the talking, I don't have to understand what you say. So in a way, it's a cover for the fact that I have difficulty with speech perception. My listening skills are not good, but I'm just going to do all the talking. Oftentimes we see individuals withdraw and isolate. The older adult who stays at home. The teenager who doesn't go out with peer groups. We see denial and avoidance. Oftentimes we see displacement. The person who says, everybody mumbles. We see significant others who compensate, sometimes overcompensate. The spouse who's always interpreting, repeating, making sure that the person with the hearing loss gets the message. The parent who's always compensating for their child's difficulty in listening situations. And we certainly see in some of our patients truly negative behaviors. And I'm certain that many of you, given your adult medical placements primarily with geriatric patients, are well aware that impatient, sarcastic, ill-tempered types of negative social interactions are not unknown in this population, particularly those with hearing loss. We also see people with hearing loss who get angry. They're angry with their family members. They're angry with coworkers. They're actually angry about the hearing aid. They feel anxious. They feel lack of control. They fear negative outcomes. If they're working adults, for example, they're worried about their job, their performance reviews, their social interactions. Others feel guilty for placing a burden on someone else. Often, persons with hearing loss will talk about that loss of self. I used to view myself as a really competent person. I was a skilled engineer. I was an attorney. I was an effective secretary. Now, I see myself as not able to do those things. And so that loss of self, that loss of self-esteem, that loss of this thing called self-efficacy. We also see patients who will tell us about their embarrassment. They're embarrassed to wear hearing aids, a cochlear implant. They're embarrassed that they need some sort of device or technology. They're embarrassed by the communication breakdowns. They are embarrassed to acknowledge that they have a hearing loss. Actually, many of those same emotions that individuals with hearing loss acknowledge, we see in parents of children with hearing loss. I can remember many times when I was the coordinator at Vanderbilt Bill Wilkerson of their early intervention program with children with hearing loss. I can remember how many families used to come into therapy and they would talk about how they hated those hearing aids. Again, with a great deal of emotion, because the hearing aid represented their child's disability or hearing loss. So it's not unusual. I can remember many times parents saying, I hate going to family events or birthday parties or other social situations where my child is different from other children in our family, other children at the 3-year-old birthday party. So it's not unusual to see the parent of a child with a hearing loss having some of these same kinds of emotional reactions to the hearing loss. Hearing loss also affects our thinking and our relationships. Many people with hearing loss talk about sort of that vague sense of worry or anxiety, that inattention, difficulty concentrating. Oftentimes, individuals with hearing loss will talk about the loss of intimacy, the inability to have meaningful, intimate conversations with those closest to them, that sense of dependency on someone else. I want to encourage you to look at the video tapes of individuals with hearing loss on the IDA Institute website. I gave you that information. The IDA Institute is a large international nonprofit organization that is dedicated to helping professionals, that means you and me, become more effective in dealing with our patients with hearing loss. And they have put together a series of ethnographic films, and I put that information up in eLearn as an attachment, both the website and some information about what you will find on that very rich website. But they've done a lot of work having individuals with hearing loss and their significant others simply talk about what it's like to live with a hearing loss, hoping that audiologists, speech-language pathologists, teachers of the deaf and hard of hearing, physicians will take the opportunity to listen to patients and begin to hear some of these effects so that we do become better counselors, so that we develop a better sense of what are the experiences, the thoughts, the feelings that our patients have. And one of the ones that always strikes me, and that typically strikes our TSU graduate students when we show it sometimes in a class, is there's a story of a young woman who is a young adult, recently married, had a hearing loss from childhood, did well, was an achiever, went to college. And sometime during her college career, she had what she describes as almost a nervous breakdown. The stress of high performance, realizing that she was different, realizing that she didn't have any intimate relationships with her sisters, with her roommates, is really, I think, thought-provoking for all of us. That little video is just a little vignette, and it's called Bringing It to the Kitchen Table, because she relates how as a child, her parents, who are part of this video, would always have their girls, their family, meet at the kitchen table over dinner to discuss family events. And she would talk about how her sisters would tell about their day, and something would come up and they would be having a family discussion, and she couldn't understand. She couldn't follow what was going on. And she would just slip away and go to her room. And over she talks about times in her life growing up as a child with a hearing loss, a teenager, a college student, and now a young adult, married, how she would just withdraw, how she didn't have the opportunity to discuss intimate issues with her family, with her peer group. And that little vignette, that ethnographic vignette, Bring It to the Kitchen Table, often impresses me with the fact that for all intents and purposes, as the SOP that worked with this young girl in school, or as the audiologist, I would have called her a star. I would have called her a success. I would have seen her family as active, engaged parents. And yet there was clearly something that was missing. And I think back on my own skills as a clinician, and would I have been sensitive enough to recognize that this family really needed help. This young woman needed counseling help, her family needed counseling help, and would I have been prepared as a clinician to provide that support? So I want to encourage you to look at that IDA Institute ethnographic videos. They're wonderful illustrations of spouses, partners, others that are, again, in the circle of people with hearing loss, and what their just emotional reactions, social, psychological reactions are. And again, we see significant others frequently angry, we see them frustrated, we see them embarrassed, we see them sometimes avoiding situations that the hearing and avoiding participating in activities. So when we think about this psychological impact that we do see in individuals with hearing loss, we also see it in our adults who come to us for therapy. They may be projecting or displacing, so they attribute their problems to others. They isolate, they're negative. Oftentimes we see people with hearing loss actually regress. They actually become more dependent. They actually do anything to avoid a communicative conflict. So they agree to things that they don't really want to do because they don't want to have discussion about, no, I'd rather not go to that restaurant. I'd really rather go to this one. It's just easier to say, whatever you want. Again, there's been a good bit of research looking at what happens to individuals who lose hearing, and that hearing serves the human organism in 3 important psychological ways. There's the basic level of simply hearing sound, and at a very primitive psychological level, being in touch with your environment, being aware of your environment. Just hearing background sound is an important way of connecting. Have you ever been in a situation where it is completely silent? There are times in my life where there's so much noise and confusion that I think silence would be wonderful. But I also am aware that silence is really sometimes frightening, actually devastating. I like background sound. It connects me to my world. At the next level, that there is that level of signal or warning. Sound helps us recognize danger, helps us go to things that are pleasant. So at a very much signal level, sounds are important to our psychological well-being. And obviously the one that we, as SOPs, are most interested in is that hearing has a symbolic level. It is language is sound. It's a major channel of communication. But we have to recognize again that lack of hearing or loss of hearing has some really profound effects on the individual, not just at the symbolic level of can I learn to talk, can I perceive speech, but at the signal or warning level, or at this even more fundamental, primitive level of am I connected to my environment. So there are some special challenges for individuals with hearing losses, and it does produce oftentimes physical or bodily stress. That's why there are times where we see individuals with hearing loss for whom relaxation training, meditation therapy, yoga, any of the more traditional approaches to stress reduction actually can be very helpful. I'm not suggesting that you, as an SOP, are going to do that, but if patients ask about that or are interested in that, it is certainly true that when you see patients with high levels of anxiety, who are really struggling with this fatigue and stress, that relaxation approaches may actually be very helpful for them. So when we think about the counseling process, what is our role as SOPs? How do we not cross over a legitimate professional boundary? How do we provide assistance to patients and families to improve communication and alleviate the problems caused by the hearing loss? Where does our role as counselor or information giver stop, and this role of another licensed professional counselor begin? I think it's really important for us to understand, and our ASHA scope of practice supports this, that because we are communication experts and because our patients with hearing loss oftentimes are experiencing these psychological effects, stress, anxiety, loneliness, depression, because of the hearing loss, we may be in the best position to provide counseling for them. That doesn't mean that we can deal with marital discord, we can deal with drug and alcohol problems, we can deal with severe anxiety. But when the problem originated as part of the hearing loss, we understand hearing loss. So we are, at least in the initial interactions with our patients, certainly able to provide what is called informational counseling. And if you look at your textbook on page 351, you'll see that Nancy Ty Murray talks about informational counseling, where we are simply helping the patient learn about the hearing loss, learn about listening device technologies, learn about services that are out there, so that the patient understands the hearing loss, knows more about the technology that they are being provided with, and the available services. That we also, though, provide personal adjustment counseling. That we can help patients work through the negative feelings that they may have about hearing loss. Help the family members move through some of these negative feelings. Develop a sense of self-worth. Learn to accept the permanency of the hearing loss, and then to look at it as a problem-solving situation. So our goal then is for the patient to regain a positive self-image, to regain their sense of self-efficacy, become willing to engage in some sort of oral rehabilitation intervention program. And so we have to think about the fact that during personal adjustment counseling, we are helping them develop the readiness to profit from the therapy that we may be able to provide. And that's true of our children with hearing loss as they move through various stages of development. So again, we are not entering into the realm of a clinical psychologist or psychiatrist. We are focused on the root of the problem through this informational counseling, personal adjustment counseling, and one other type of counseling that we want to think about is what's called rational acceptance, helping the client and the family reach that point where they are ready to benefit from therapy, communication strategies, auditory training, speech reading, speech and language and literacy training for children, learning to manage the loss in an appropriate way. So again, our goals differ with each one of these three types of counseling. And we need to be clear as we set up an intervention plan for a client and their family. Where are we? What kind of counseling are we doing? And what is our goal in that counseling? It's important for us to remember that we have to develop those characteristics of a good listener. We have to be the generous listener, the non-judgmental listener, the empathetic listener. We have to be ready to listen to what our client may be telling us between the lines of the direct comments. So again, we need to be sensitive to what is not being said as well as what is being said. We need to learn the difference between what Clark and Frederick call troubles talk, where the patient tells you all the things that are the matter, how badly their day or week has gone. And that's when your patient needs reassurance. But you also want to help them move beyond just troubles talk to problem-solving talk, where you begin to help them move from "it's been terrible" to "what can I do? How can this be changed? What strategies can I use?" So that, again, it's a balance and it's a movement forward. Both of those are important at different stages. So it is important to be empathetic, to listen to our client, to hear their troubles talk, and provide reassurance. But it's also important to help them move to problem-solving talk, to communicate to them that we indeed believe that they are capable of solving their own problems. And we might use a variety of different approaches, whether we use a cognitive approach, a rational emotive behavior therapy approach, whether we use a more behavioral approach, whether we use a Rogerian affective approach. Again, our goal is to help the patient move forward. One of the things that when we think about how we counsel as healthcare providers, there's been a lot of work that has been done in the field of medicine and related healthcare services to talk about what kind of counseling is it that we do, those of us who are healthcare providers, where we actually are trying to get our patients to participate in therapy, to implement an intervention, to implement a different lifestyle. So we have counseling as a foundation for moving our patients into some sort of behavior change. And this thing called the 4 habits model of counseling, I put some information up in eLearn about the 4 habits model. It talks about investing in the beginning. This model was actually developed for physicians. How can a physician use a brief encounter with the patient to be a good counselor, but to move the patient to being compliant with whatever the recommendation is, taking your medicine to control your hypertension, eating a healthy diet in addition to your insulin if you're a diabetic. But talking about in a short encounter as a healthcare provider, how can we develop habits of our own in our own counseling of our patients to move our patients to action or behavior change. And the first habit is invest in the beginning. Immediately attempt to establish rapport with that patient when you first meet them. Elicit their concerns. Tell them what you want to do during your visit, but elicit from them what they want from you, so that they are active participants in how are we going to spend our therapy time together. Elicit immediately the patient's perspective. Ask for the patient's ideas. Elicit specifically, what can I do for you? What do you want to talk about? How is this hearing loss affecting your life? Then demonstrate empathy. Be open to the patient's emotions. Make an empathetic statement. Convey empathy non-verbally. Be aware of your own reactions. Make sure that you are not conveying judgment. No matter what your patient says. Your first response has to be unconditional positive regard from Carl Rogers' principles of affective counseling. You have to assume that somehow, in some way, your patients know best, that they do have the inner resources to overcome their communication difficulties. Right now, they may not be using them. Right now, they may not be demonstrating them, but they do have that potential. So that unconditional positive regard on your part engenders then that sort of non-threatening context so that the patient can express their concerns about their hearing loss, their difficult feelings about their communication difficulties, their apprehension about their devices, and then can begin to move toward a solution. Then the fourth habit model for effective information counseling for healthcare providers is this idea of invest in the end, so that the closure of your therapy session that may have many different components to it, including more traditional AR kinds of things. Make sure you give them good diagnostic information. Make sure you give them education about why you're asking them to do whatever it is. Involve the patient in making decisions. What would you like to tackle next? How would you like to practice this? And then bring the visit to a close. There's a lot more information about that four habits model on this thing called the IDA Institute that I've given you the website to. There's another model for getting behavior change in AR counseling, specifically directed toward hearing loss, again, from the IDA Institute. And it says that we have the 5 A's model of behavior change. Assess the patient's level of behavior. Advise the patient based on their personal health history or health risk. So personally, what are the difficult situations for you? Personally, what is the degree of your hearing loss? What is the particular device that you're using? Agree with the patient on a realistic set of goals. Remember again, this is patient-focused therapy. The patient sets the goals with our help so that the goals are realistic, but the patient sets the goals. Then assist the patient in anticipating where there are going to be bumps in the road. Develop an action plan with the patient, and then arrange for some sort of follow-up and support. So our role as a counselor is to assess, advise, agree with a plan that the patient takes some responsibility for, assisting the patient in implementing his or her plan to change communication, to increase use of wearing time with the hearing aid, and arrange for some sort of follow-up. When we think about the stages of a counseling relationship, it's important for us to recognize that our goal is always to work ourselves out of a job. Our goal is to think about the end even as we begin. So our entry into a counseling relationship with a parent of a child, with an adult with a hearing loss, is to establish rapport, to see the client as a person, a whole person, to clarify what the patient's problem is, to determine how that hearing loss is affecting that person's quality of life. Then to identify where can that client get help? Is it from our therapy? Is it from someone else? Is it from a computer-assisted instructional pattern because they're not going to be able to come to therapy? Then if the patient decides to engage in some longer-term therapy, may still be short, but longer-term, to establish a therapeutic relationship, to outline an intervention strategy, to get the patient to agree to participate. The patient is a part of the plan. But you're then fairly quickly going to move into planning for it to be over. Planning for, we've learned these specific communication strategies. We've worked on this auditory training. We've talked about your hearing aid and how to manage your hearing aid and troubleshoot your hearing aid. Let's talk about now generalizing those skills and then be ready to terminate. Again, AR in particular is not long-term in many, many cases. So again, we want to be thinking about helping our patient develop the coping strategies. We want to be helping our patient develop skills. Again, we're going to address those maybe in some short-term therapy, but developing anticipatory strategies, repair strategies, guidelines for listeners and speakers. One of the things I want to call to your attention is that if you look on this IDA Institute website and you look at some of the handouts from the IDA Institute called motivational tools that I put attached to the news announcement, but also in the content section in eLearn, it's important that we think about how can we get the client to take ownership of the problem. How do we help our patients become actively engaged in their own therapy? And that's where supportive counseling and what is sometimes called motivational interviewing come into play. And so this IDA Institute for people who are professionals helping individuals with hearing loss have said that if we truly believe in a person-centered counseling style, then it's important that we get good at helping our clients learn to tell us where they are. And the IDA Institute has come up with 3 really simple yet effective tools for opening the conversation with your client about how do you feel about your hearing loss, what are you willing to do, what would work for you. If you look on the IDA Institute website, you'll see tools. And the tools are really simple. They're the circle, the line, and the box. And they are nothing but little graphics that we as clinicians can use to open a dialogue with our patients about their hearing problems, their willingness to do something about their hearing. So the line is one of those motivational tools. It's nothing but a line from 1 to 10. It's simply a simple little tool that enables you to say to the patient, show me how ready you think you are to take an active role in participating in AR. Do you think you are ready to participate? Are you ready to wear a hearing aid? Are you ready to participate in auditory training? Are you ready to come to a communication strategies group meeting? It doesn't, and you simply ask the patient to show you from 1 to 10, where are you in terms of being ready? Or how important is it to you personally to improve your hearing? So you get a sense, again, for what is the patient's attitude. If they are not ready, then you're in a very different place from they are ready. The box is another patient motivation tool from the IDA Institute. And again, it's simply a graphic. It's simply a way to open a dialogue with a patient about their ambivalence. It can be used in combination with the line that may help patients be aware of sort of where are they really when they think about their hearing loss. Using the box can help you as a clinician assess patient motivation and to explore what might motivate them, support them to change their behavior, take a more active role in solving their own problems. So it's simply sort of a pro-con. You list the things that when I think about my hearing loss and my ability to work through my hearing problems, what are the good things? What are the not so good things? What are the good things about using my hearing aid? What are the not so good things? So where am I? The circle, another very simple graphic, is a framework that you can use to get a sense of how ready the patient is, again, to change behavior. It helps you look at sort of the stages that all of us go through in the process of making a change. It lets you as a clinician talk with your patient using a really simple little graphic. Where are you in terms of being ready to use your hearing aid, use your cochlear implant, participate in therapy? So are you just contemplating doing that? Are you ready to do that? And this little circle framework, this little graphic, simply helps you as a clinician have something that if you don't feel that you have had a lot of coursework or a lot of practicum in counseling and you go, I'm not sure how to start even a conversation with my patient about these. These little line, box, and circles are just simply that. They're tools to start opening a conversation about that. The IDA Institute has also developed some tools for children. And one of the counseling tools for counseling children is called My World. And again, it's for those of us who are SLPs, audiologists, teachers of hearing impaired, people who don't have a formal license and maybe not a lot of training in counseling. How can we get a view of how our child or adolescent patients actually see their hearing loss? So the My World tool consists of what looks like a little dollhouse or a little house scenario with 3 different environments: a classroom, a home, an outdoors area, where the child or the adolescent moves little figures that are just paper little figures and everyday objects in the various environments. But because we know that our child clients with hearing loss oftentimes are not skilled, efficient communicators about abstract, intimate thoughts. Oftentimes using this little diorama helps them communicate to us what they're feeling, what they're thinking. So by playing with these figures and objects in these different environments, at home, at school, outside, the child or adolescents can externalize their hearing loss. They can discuss how they communicate with others in a really concrete way, role-playing in effect with these characters in a non-threatening way. That too has been used a lot to help SOPs and audiologists, educational audiologists, uncover information about the child's communication patterns, reinforcing the positive ones and developing a strategy to cope with the everyday challenges that the child may be experiencing, but not necessarily in a position to share verbally. So it is a little like play therapy. It is a little bit like using puppets to play out a scenario. This has been used in a lot of the big cochlear implant programs. So medical centers that do a lot of child cochlear implantation and work with children getting CIs early on oftentimes use this particular tool called My World. But it's another tool that is on the IDA Institute website. Again, it's a quick tool that you can start a conversation with the child or the adolescent about those environments. They have one called the Quick Tool that gives you some possible questions to ask about as you explore, having the child tell you about what's daily life at home like, what it's like in the classroom, what is it like doing outside activities. Again, you always have to keep in mind that your conversation with the child should always focus on topics and challenges that are important to that child. And that's this quick tool, this set of little questions gives you a way to start figuring out what is going on with that youngster. What are the trouble spots in their communication? When we think about counseling families of children with hearing loss, we need to recognize that the goals of family-centered counseling are always to promote positive family functioning, to, again, convey to families that we have confidence that they will be able to meet the challenges of having a child with a hearing loss. Our goal is always to empower them to identify their strengths, identify their resources, to help them use the formal and informal social networks that they already have to provide support to the parents and to the child, to make certain that we are helping families build positive, mutually satisfying family-child relationships. So as an SOP, we do provide counseling, whether we call it that or not. It's part of our interaction with our families of children with hearing loss and our adults with long-standing hearing loss, whether they have sudden acquired hearing losses or these gradual presbycusic hearing losses. We provide counseling for adults with long-standing hearing loss as well. Counseling involves the recognition that we are dealing with a loss of a kind. We are dealing with the effects that hearing loss has on all aspects of the person and the family's life. And that counseling includes both emotional support, but also assistance in problem solving and helping our patients move into that problem solving position, so that we want to have them move to, as your textbook talks about on page 366 and 367. We want to move our patients to a problem-solving approach so that they see this hearing loss as simply one more of life's challenges. One more of life's challenges that they are fully capable of meeting, and that we need to help them with strategies, but we are confident that they can solve that problem, whatever communication difficulty they find that they have. I want to remind you that once you finish chapter 10, and this lecture 9 and 10 will be on your midterm, your goal then is to make certain you've turned in your chapter questions on 9 and 10, and that you open the midterm exam. We did a review for the midterm exam on Wednesday night, the 28th. If you need to review that midterm exam study guide, go back and listen to the archives from June the 28th, because I did at the end of that lecture review exactly the things that are going to be on the midterm. Remember that your midterm is 2 hours, unless you have an accommodation, and then you may have extended time. But it is 2 hours. Once you open the exam, you have 2 hours to complete it. You may choose when to take it. It is open from July the 5th to July the 10th, but it closes at midnight on July the 10th. So make sure you think about your time, that you work through when is the best time for you to study and take that exam. You do have a discussion question due this upcoming week, so it is not due until Tuesday the 11th. It is to use the CID everyday sentences from the end of chapter 2 in your textbook with a partner of your own choosing, and to play both the listener role and the speaker role. Again, so that you gain, hopefully, a perspective on what it's like to be a person with a hearing loss in challenging listening and lip reading situations, but also what it's like to be the partner of a person with a hearing loss, to see if you can gain, again, some sense of what your clients and their significant others are experiencing, so that you do become a better counselor. So good luck on your midterm. Please feel free to email me if you have any questions, and I will be looking for your 9 and 10 chapter questions, looking for your completion of your midterm, and looking forward to reading your discussion on the ID, everyday sentences, little scenarios. Have a good week, and I will look forward to being with you again on the next Wednesday, July the 12th. Good night, everyone.